using the handmade pads, but of course disposable cost factor is there, and of course leakage from that pad, limitation of clothing. Fortunately, in our country, most of the village women, they are coming with this problem, and they are wearing a sari, 6-meter sari. And when I was a very young faculty, I still remember Lavanya, Dr. Lavanya was supposed to be a urogynecologist at that time from Manipal. So she was speaking about stress incontinence, and she said that stress incontinence is not a problem of our country because we wear sari and 6-meter can accommodate a lot of urine. But I don't agree with her. Like it, anyway, the bad odor will be there. The sari, the urine may not be visible. Then, of course, toilet mapping. So those who have a urinary problem, कहीं जाना है वहाँ toilet मिलेगा या नहीं? नहीं है toilet, I will not go. So and wherever they go, they start looking for a toilet. कि कहाँ, where is the toilet where I can go in case of need? And of course, they become housebound. Yet they may take years to present for help, as we have been talking, because of embarrassment, and they accept that it is normal after producing kids. So they don't go anywhere for help. I would like to list this food because this has not been told so far. So while taking the history of increased frequency, urgency, you should also be taking what type of food that she is consuming. The food which are known to cause increased frequency are caffeine, of course, coffee, tea, we all experience after drinking and how many times we go to toilet, and alcohol. Fortunately, not a problem, but these days it is becoming popular even in our female population. Carbonated drink जो बहुत popular है, Coca-Cola or Pepsi and all those things, they cause bladder irritation. Citrus fruits are also good to taste, but they are notorious for bladder. Then spicy food, chocolate, because it contains caffeine, sugar or honey, that can also irritate bladder. And then artificial sweetener, which is very popular for especially those who are having weight reduction and they have a sweet tooth, they take sweetener, but that also irritate bladder. And of course, tomato, the food which has tomato puree and all, they cause increased frequency. So in patient with symptom desiring treatment, a discussion of treatment option should start with conservative non-surgical. We talk so much, but still the awareness is so less. Like I was today seeing my patient, and one of the case who came has stress incontinence, and as soon as I saw urine was coming out, and she was never in the life, they did a vaginal hysterectomy, but nobody ever advised her to have a pelvic floor training, which we will be talking shortly. Then many patients, they are unaware, and there are available non-surgical method also. Behavioral treatment is the gold standard for stress urinary incontinence. Of course, focus will be on changing the behavior. How that is done, I will come on to that. And of course, multi-component interventions like pelvic floor muscle training, exercise and bladder training, estrogen treatment only in those cases who are deficient in estrogen. So for SUI, the management, of course, as I said that first treatment is non-surgical, but of course it depends on type and severity of incontinence, what treatment has she got in the past, comorbidities which are associated with it, with her, then medical condition, willingness to participate in conservative surgery. Then for pelvic organ prolapse, for major type of pelvic organ prolapse, non-surgical treatment is not effective, but for the milder form and for prevention of pelvic organ prolapse, pelvic floor muscle training is very, very important. These treatments are particularly valuable for patients who are unable or unwilling to undergo surgery, or they are unfit case, that we have a non-surgical method, and the goal is to offer optimal individualized non-surgical care for both pelvic organ prolapse and SUI. Every time my finger is going, they are thinking that my laptop is here. So much accustomed, sometimes, you reflexly, my finger is going there, that let me change my slide. So I'll be talking about bladder diary. So what is it is, and Shazia will make, I think she will make a bladder diary for the Department of Obstetrics and Gynecology shortly. What we did so far, we used to draw it on a paper and used to give it to the patient to maintain that bladder diary. So what all things are there in that bladder diary? Date and time, AM or PM, the exact amount of urine that she has passed on that point of time, whether she drank any water, any type of fluid, tea, water, coffee, drink, whatever she has taken, that volume has to be mentioned, whether she leaked, like whether it was accidental leak, and urgency, how much was the urgency, and I will tell you on a scale, how do you describe on a scale, and description, like maybe what was she doing at that point of time. Maybe she was in market, she was shopping, she was somewhere and she had all these problems. At that point of time, she will note that what leakage, if it has occurred, what was she doing at that time. So bladder diary has to be maintained. Why it is considered to be so important? Because bladder diary will identify those cases with increased voiding frequency, contributing to reduce bladder capacity, and again she is going to toilet, and this capacity goes on decreasing, or benefit for those women who leak because of full bladder. They don't pass urine for hours and they are leaking. So these information we are going to get. So the bladder diary, this is the bladder diary which is from NHS, and it has mentioned everything. About urge incontinence, instruction I'll be reading later on because it is too small, you can't read it. But at the urgency, how do we grade urgency? From 0 to 4. So 0 is she does not have any urgency. She has gone to toilet just in case कि कहीं leak न कर जाए, चलो चलते हैं. So that there was no urgency, but she has gone. So that is 0. 1 is she has urgency, but she can hold her urine for 1 hour without passing. Then 2 is when she can hold it just for 30 minutes. 3 is when she is able to hold it for 15 minutes. And worst is 4, when she is not able to hold it, or just for 5 minutes, she has to rush to toilet. She cannot hold it for more than 5 minutes. That is 0 to 4 is for urge incontinence. And for stress incontinence, if there is no leakage of urine, it is 0. 1 is minimal leakage only with significant stress. Then 2 is moderate leakage with moderate stress. 3 is frequent leakage with moderate stress. 4 is heavy leakage with minimal stress, that means severity has increased. And constant leakage with minimal or no stress at all is 5. I could not get, like when I search this bladder diary, which is from the textbook of urogynecology by Mickey Karram. He has mentioned it to the scale of 0 to 4, but I could not get it. All that I got for stress incontinence, it was on the scale of 0 to 5. So I modified it. It was on because it was mentioned 0 to 5. Now for 3 full days, she is expected to maintain it. So what instruction is to be given? Start the chart with the morning void. That means as soon as she gets up in the morning, she mentions that how much urine she has passed, and then complete it for 24 hours for 3 consecutive days. So the last day will be the 4th day morning. When she will be coming to us, she will be the last sample morning void that she will be collecting will be on the 4th day, and she has to document on that diary when did she go to bed and when did she get up and how much water she consumed at night. Though those who have frequency, we tell them not to consume lot of water at bedtime, but at least 3 to 4 hours prior to going to bed, they can have some water. So everything is documented there. Once she comes to us, we have to do the analysis part. So in analysis, what all we are going to do is, we will have to see that how much she, on day 1, 2, 3, how much urine did she produce, how much water that she consumed, water or liquid that she consumed, what was the frequency in 24 hours during the daytime and during the night time, and average urine volume per day. That analysis part has to be done by healthcare professional who can see that 3 days diary and can analyze. Then what was, when she has an urge to pass urine, how much urine did she pass? Was it a very small volume or was it a big volume that she passed during the urge? So that urine output during the urge, how much did she pass, that is mentioned, and all these things are then analyzed to find out what is the reason, whether she is really having increased frequency or not. And all these 3 days are her normal days. They should not be those days when she is partying and she is having a lot of drink for some reason, like these days are not, that should not be there in the bladder diary. They are all the normal days that she spends. And now, after she has completed and we have done the analysis, we are going to do certain things to her. One is pelvic floor exercise and the other is bladder training. So I am going to talk about them one by one. Pelvic floor musculature training and exercise are Kegel exercise, which was given by Kegel way back in 1948. He realized the importance, but we neglected and we never asked our patient to have Kegel exercise. And what to talk of the patient? Every woman should do the Kegel exercise because it is such an excellent exercise that take care of so many pelvic floor disorder and urinary disorder cases. So, let me tell you what is actually, I'll not read from there here. In pelvic floor exercise, what do we ask our patient to do? We ask the patient to empty the bladder and to think that she is going somewhere, she does not find a toilet and she has to hold her urine, or she is in a mehfil and she does not want to fart and she has to hold that part to prevent it. And we have been doing it involuntarily many a times that we want to stop urine or we want to stop that fart part. So we ask her to empty the bladder and try to hold it without taking any, and without exercising any other muscle. So remember one thing, pelvic floor muscle exercise is one exercise which is not seen by doing, when the women is doing. I am doing pelvic floor exercise. Can you make out? Can anyone sitting here? I am strongly doing it. Can anyone make out? You are also. So, pelvic floor muscle exercise can be done sitting, lying, standing, driving, anywhere she can do. तो ये बहाना तो चलेगा नहीं कि हमें तो टाइम नहीं मिलता है, हम नहीं कर सकते. अरे तुम किचन में काम करती हो ना, वहीं कर लो. कहाँ, कहीं कहीं, जहाँ जहाँ तुम जा करके फील्ड में काम करती हो उधर ही कर लो, क्या है. So, but they just have to use that correct muscle. अच्छा, मैंने अपनी एक पेशेंट को अभी थोड़े दिन पहले, अभी जब after leaving the medical college and that patient was well off. So I was explaining to her, she has this problem and she was old also and she never did pelvic floor exercise. So I was explaining to her कि think that you are traveling in a bus, the bus doesn't stop according to your wish, and you have lot of desire of passing urine and you have to hold it. Then she said, nahi, hum bus mein kabhi nahi jate hain, hum to car mein jate hain. तो ऐसी ऐसी भी बातें सुनने को मिलेगी. सो यू कैन से दैट कि ये तुम्हें करना है, जैसे तुम्हें टॉयलेट नहीं मिल रहा है और तुम्हें होल्ड करना है. सो दे विल डू इट करेक्ट. So they just have to do the correct muscle that has to be exercised. And what, like how will you instruct her to do it? Once you have taught her, tell her that once you hold it, count. Initially, you may not be able to count to 10, count to 3, count to 4, just 3-4 seconds, and then relax it totally. Again, do it. Relax totally. That means the time that you spend in doing the exercise, the same time you spent in relaxing your pelvic muscle. It is very important. Doing all the time does not help, because pelvic muscle will be fatigued like any other muscle in the body. So how many? 30 to 45 per day. How many per sitting? 10 to 15 per sitting. How many seconds are they going to hold? Around 10 seconds. And then relaxation for 10 to 15 seconds. That has to be done. So its role in stress and urge incontinence is well known, but for pelvic organ prolapse, unclear, but in milder form, we do advise them. And how it is helpful. It is hypothesized that improving pelvic floor muscle function may improve structural support of the pelvic organ through muscle bulking or stiffness to improve pelvic floor symptoms. So this is how you do it. And this is from Mickey Karam, Dr. Afsha, and they have mentioned that only once per day, practice stopping or slowing the stream of urine when you void. So I have purposefully not deleted this, because at many places they have mentioned that while passing urine, you should never hold back. But they have said, that book has said that only once per day, you should do that. And of course, doing it slowly and relaxation is important. But per day, 3 to 4 quick and strong Kegel exercise should be done. Why? At least एक दिन में 3-4 बार बड़ा strong सा Kegel exercise करना है, फिर relax कर देना है. Because this action will help. When they are coughing, sneezing, they can do that, and cough and sneeze, they will not leak. So this practice should also be there, doing a strong Kegel at least 3 to 4 times in a day. So this was about Kegel exercise, and how does it help in stress incontinence? Because we as a doctor should know the scientific basis of doing anything. Then only we are convinced, and we can convince our patient for doing it. So this improves the urethral support. Patient learn to use their muscle actively to prevent urine loss during physical exertion, coughing, sneezing, lifting some weight. With practice, they develop the habit of consciously contracting the pelvic muscle to occlude the urethra before and during coughing, sneezing, or other activity which causes urine loss. They learn it. How about urge incontinence? Does it help in urge incontinence? So urge suppression strategies are: traditionally, pelvic floor training muscle exercise was used almost exclusively for stress, but the voluntary pelvic muscle contraction can also inhibit detrusor action. So this will inhibit the detrusor contraction, and it is used as a component of behavioral treatment of urge urinary incontinence as well. So patient of urge incontinence are also taught, instead of rushing to toilet, what should they do? Like एकदम से urge आई, क्या उसको हमें सिखाना है? जब तुम्हें लगे कि बहुत तेज यूरिन पास करने की अर्ज है, don't rush to toilet. Sit down, relax, distract your mind. Then once and after relaxing, do Kegel exercise also you can continue doing it, and once that urge has gone, then you can go to toilet. So cheat your bladder. Like the bladder is cheating you, you also cheat. I am not going to go to toilet. I will relax. Then, and of course, that urge period should go on increasing every day. So, in pelvic organ prolapse, I have already said that it will improve the tone of the muscles. Uh, then adherence and maintenance of pelvic floor exercise is important. Like whenever you ask your patient to do, tell them to continue doing it. Whenever they remember, they should do at least one, twice, thrice, they should do. And when the result comes, like एक हफ्ते के बाद मरीज आ जाएगा अगर आपने नहीं बताया है कि रिजल्ट इतनी जल्दी नहीं आएगा. At least 4 weeks, wait for 4 weeks, the result will start coming, and once the result start coming they can go on doing it. And of course follow up is very important, because to track and reinforce patient progress and encourage persistence, for that follow up is also very important in these cases. So they can maintain. Yesterday Afsha was talking something about electric nerve stimulation. I have never done it, I have never seen it, but what I have read from the books is pelvic floor electric stimulation. That is, that as you have said, that they take the sitting of around, for vaginal exercises, they take a sitting of 15 minutes twice a day, every day, or every other day. Once they improve or they are cured, then 2 to 3 treatment per week they can go on to that. But as it is not available, once we don't see something, it is very hard to talk about that. Then, yeah, sure.
What I was talking about yesterday was PTNS, which was posterior tibial nerve stimulation,
Yeah.
which is our medial malleolus, just there. So we put an electrode, which is like an acupuncture, and that is attached to a machine similar what Dr. Seema showed. So it gives it continuous stimulus to posterior tibial nerve, and that is a treatment for overactive bladder. Okay. So what Dr. Seema is talking about, this is called Kegel
muscle
machine, and there are various variation, and this is available for India as well. So anybody who is finding it difficult to do pelvic floor exercises, I'm sure quite a few of us in this hall are struggling to do pelvic floor exercises. So this is a good one to buy. In England, we can buy this for 60 or 70 pounds. So there is a little probe, which is just like my finger. So it is a vaginal probe. You put that probe in vagina, and this is like a battery. So you increase the strength of the stimulus. So it's electrical stimulation. You can start from mild, moderate, and then strong. So this does exactly same what we do pelvic floor exercises. Because sometimes what happens with denervation injuries like childbirth, forceps deliveries, or our nerves are not working, sometimes it's difficult to do these exercises. So this machine can do. So just 15-minute session every day. So sometimes if you can afford that, it's something good to have. So it is in the vagina. So it's a probe exactly like a finger. You put inside that probe inside your vagina. So this battery you keep in your hand or put it on the side table. So that probe remains inside for 15 minutes, and this electrically it stimulates the vaginal muscle. So it exactly does the same thing. Exactly. It is something like so it can be bought. And I think these things, because when India is so much advanced in technology, I'm sure it is available on Amazon, because so many of
Let's
my
see on
patients.
Amazon if it is available. We
Original
can
price
have
was
this.
300-400 pounds for the original Kegel machine, but a lot more companies are making it. Now it is 60-70 pounds. But I
But
get very surprised that why in India nobody has done this technology stuff, while India
no,
is so
maybe it is
advanced.
available. We have not seen it.
Maybe.
So I have never seen it. I have never used it for any patient. So
Yeah, this is one of the common things
maybe
in
we'll
England.
do more
And
research.
another thing which is common, which is vaginal weights. Have you got a slide on this?
No, no, no.
Vaginal
Vaginal
cones on weight.
cones
This is
are
that is a
there.
cheaper version without electricity.
So further, Hmm. That assess. Yeah. Yeah, yeah. What is bladder training? Actually, this is an intervention which patient has to teach the bladder actually that how frequently the bladder need to be emptied. So what the normal scenario for urgency will be that they will have a urgency. They have to sit and be stable or stop wherever they are. First, squeeze pelvic muscle quickly, at least 4 to 5 times. Wait for a few minutes. Then, if urgency persists, use distraction strategies. Once urgency lessens or stops, then wait for 5 minutes and then slowly walk to the toilet to pass urine. And this has to be done like there are 5 steps of bladder training that they maintain their bladder diary, then each day calculate the amount of hours that you wait between each urination. Then based on that calculation, choose an interval long enough to hold between urinating and empty the bladder first thing in the morning. Of course, that we have to tell every patient, and add 15 minutes to each interval. So maybe they don't have to prolong it for a long time. They can start with the 5, 10 minutes, 15 minutes, and then they go on increasing in between. Like if they are able to lessen the urgency, put off passing urine for 5 minutes, then 15 to 20 minutes, and till they come to 3 to 4 times, 3 to 4 hours. Sorry, when they are awake, it should be around 3 to 4 hours interval that they should pass urine, and during night time, depending on their age, younger age group they don't get up, but older age group maybe two times they can get up at night for passing urine in the older age group. Though Shazia has said one time, anything more than one is nocturia, but if they are postmenopausal, they will get up more as compared to premenopausal. So what does the evidence says? How does bladder training helps? So a randomized trial has shown 57% reduction in incontinence in older women, that it reduces both urgency and stress incontinence. Urgency incontinence by increasing bladder capacity and reducing its overactivity, and stress incontinence by strengthening the muscles which are responsible for holding back the urine during coughing and sneezing. And of course, additional benefit will be potential strengthening of pelvic muscle through postponing urination. So, when will a change occur when we are going for behavioral therapy? Do not expect anything so quick. In 3 to 4 weeks time, one should be able to see the improvement, and so we should always encourage the patient to continue it, and they should not be discouraged if they are not able to see the quick result of doing exercise. Then bowel management is important, as Dr. Afsha has already mentioned, that during constipation, they can have retention of urine or incomplete emptying of urine. So we should always give them dietary advice so that they do not have constipation, and laxative can be given as a last resort if they are not responding to your high fiber diet advice. Then weight reduction, again from that lecture, what I remember was overweight female has more stress incontinence, and Lavanya that time showed J. Jayalalitha's photo and said that overweight is responsible for stress urinary incontinence. So it is seen that every 5 unit increase in BMI lead to 20 to 70% increase in the risk of prevalent incontinence. So weight reduction strategy is good point for curing stress urinary incontinence. About estrogen also we have talked, so I am skipping this because she yesterday mentioned the dose and everything, that what are the cases who are going to respond to estrogen therapy. For pharmacological duloxetine also she mentioned, that is though not FDA approved for use in stress urinary incontinence. So let us go on to the demonstration